This is actually a great meeting for everybody to attend, including me. You're actually very fortunate. There's really a kind of who's who as far as experts in the world of OCD here. And so we're very fortunate to have all these people volunteering their time. So like Dr. Simpson said, today I'm going to be talking with you about using medications to treat OCD. I'm going to try to teach everything you ever wanted to know in a half hour. So we might have to keep a somewhat brisk pace. Like Dr. Simpson said, that we know that there are some circuits in the brain that might not be functioning well. And the way the brain works is that each brain area is made up of lots of cells called neurons. And the way one neuron talks to the other neuron is by releasing neurotransmitters. And we have several different types of neurotransmitters in the brain. And the medications we use affect the amount of those transmitters and also can hit the receptors for those transmitters directly, either causing them to fire or blocking them. For many years, there was a long period of time where we had a lot of good medication treatments for depression and anxiety, but nothing for OCD. And then we were very fortunate that people like Dr. Nezaroglu, who will be speaking later, and her husband, Dr. Yura, started looking at a particular medication called clomipramine. And clomipramine is part of a class of medications we call tricyclic antidepressants. And the other tricyclic antidepressants didn't seem to work very well. And yet, for some reason, clomipramine did. So what's so special about clomipramine? So other tricyclic antidepressants affected two main neurotransmitters, predominantly norepinephrine. And they had some effects on the serotonin system, but not really strong effects. Clomipramine, however, was the first drug that really had potent effects on serotonin. The way that clomipramine affects serotonin is by preventing its reuptake. And so clomipramine is often known as a SRI, serotonin reuptake inhibitor. So we have finally a drug for OCD, all is well, and then we got a lot of side effects. Many people actually respond very well to clomipramine and tolerate it very well, but some people get more side effects. The most common side effects that we're going to see with a drug like clomipramine and other drugs in that class called tricyclics are what we call anticholinergic effects. And because what's happening with clomipramine is that we're affecting serotonin, but it doesn't affect serotonin alone. And one of the things it does is it blocks another brain chemical called acetylcholine. And when it blocks that, we can get what are called anticholinergic effects. The very crude way I often describe it to patients is think of everything that normally comes out of you, it comes out less. And so saliva in your mouth, less. So people tend to get dry mouth. Urination. People sometimes have urinary hesitancy. It's hard for them to urinate. People get constipation. Other symptoms can be sometimes weight gain, as well as some sedation. The most concerning side effects, which happen fairly rarely and usually only at higher doses, are the occurrence of seizures and abnormal heart rhythms. Again, these are low incidence of these, but they do happen at the higher doses and something we have to be careful about. In the depressed population, the other thing we're concerned about with tricyclics is that an overdose, they can actually be lethal. So knowing that we finally had a medication that worked, and we knew it worked by blocking the reuptake of serotonin, we began to look at another class of drugs called the serotonin reuptake inhibitors, and these were actually called selective serotonin reuptake inhibitors. So unlike clomipramine that tended to affect a lot of neurotransmitter systems, SSRIs were more focused on serotonin, but they still actually also have other effects. And so, as you're probably aware, these are some of the SSRIs: Celexa, Lexapro, Prozac, Luvox, Paxil, and Zoloft. One of the things I always like to make clear to people is that in our kind of society, we've kind of equated the word SSRI with antidepressant. And that's actually not necessarily the case. And so even though all of the SSRIs are antidepressants, can be used to treat depression, not all antidepressants are SSRIs. And so some antidepressants don't affect serotonin at all. A drug like Wellbutrin affects more dopamine and norepinephrine. And the lack of its effect on serotonin renders it not very useful for disorders like OCD. And actually, there are other drugs that actually affect serotonin in a different way than blocking its reuptake. Some of those have some evidence of working, but the real class that we see works for OCD are, again, things that affect serotonin in a very specific way, and that is blocking its reuptake. And we're going to go over that a little bit more. So, SSRIs, how often are they effective? And SSRIs look like they're effective approximately in 50% of patients. Not really the numbers we'd like, but a good number of patients actually get some effect. The more important question is, what does it mean for a medication to be effective? Because often our initial kind of instinct is if something's effective, if I have something, get rid of it. And that's actually not the case. And so when we treat disorders like depression, we're actually trying to get what we call remission, complete or almost complete absence of symptoms. This is not something that happens often when we treat OCD. And so we know that out of the approximately 50% of patients that respond, approximate 20 to 40% decrease in OCD symptoms. And we know that a 20 to 40% decrease often correlates with a decent improvement in quality of life. But as you might suspect, if you have a lot of OCD or severe OCD, that often even with that 20 to 40% reduction, people still have a lot of symptoms left. Somebody responding completely to an SSRI, where they have complete remission of their OCD, is unfortunately an all too rare event. So this is a very common question, right? We talked about clomipramine early on, which was the first drug for OCD. And the question is what's more effective, clomipramine or the SSRIs? And so we look at things called meta-analysis. And meta-analysis is taking a lot of different studies from different time periods of different drugs and kind of lumping them together to try to figure more things out about how these drugs compare to one another and how they compare over a large population. Some meta-analysis have suggested that clomipramine has an edge. It's slightly better for OCD than the SSRIs. It can be a problem, these meta-analysis, because it's very difficult to compare studies due to being done at different times, under different conditions. One big problem is that it seems like that the placebo rate that we get in studies has gone up over the years. And so if a drug, let's say, worked 50% improvement in symptoms, but a placebo had 30%, it looks much better than a drug that works 50% of the time and has a 40% placebo response. And so again, it's very hard to necessarily judge using a meta-analysis. If we look at more head-to-head studies of one drug against the other, it appears that there's no real difference in effectiveness of clomipramine or SSRIs. Now, just because some research shows that that's still an issue of controversy in the field, and some people clearly still think that there's something different about clomipramine that works possibly a little better. But due to the fact that the SSRIs tend to have less adverse effects than clomipramine, and knowing that they might probably have the same efficacy, we tend to use as the first-line treatment the SSRIs. The SSRIs, unfortunately, aren't devoid of side effects. Most side effects from SSRIs are in the mild to moderate range, and they tend to be very well-tolerated drugs. Most of the side effects people get with the SSRIs are usually early on in treatment, usually within the first couple of weeks. Those symptoms are relatively transitory and usually remit pretty shortly. And the most common of those being people can get some GI upset, the gastrointestinal tract, they can get a little nausea, upset stomach. People can also get headaches. And again, that usually tends to remit over the course of a few weeks. The more long-lasting side effects, and one of the reasons for people decreased compliance and not wanting to be on the medications, is sometimes they can have some effects on sexual functioning in both males and females. And people can also get insomnia or somnolence, which is just being tired. As well as people can get weight gain. The weight gain with SSRIs tends not to be severe. We tend to see a lot more severe weight gain with other drugs like antipsychotics and some of the mood stabilizers. But people can gain some weight on SSRIs. Typically, again, it's a few pounds, rarely kind of more than 10 or so, but people do. And so this is another huge question. Is there a best SSRI for OCD? And when we look at it, it doesn't appear that any one SSRI is any better than another for the treatment of OCD. There is kind of some lore, and probably the most common one I get asked about is Luvox. Should I be on Luvox? Is it the best? And part of that comes from Luvox being the first drug to get an indication for OCD. But again, there doesn't seem to be clear evidence that any one medication is better than another. But actually, to patients, this is the more important question. Who cares about everybody else's OCD? For my OCD, is there a best drug? And Dr. Simpson alluded to the fact that OCD probably has a number of different causes and a number of different ways that circuits get affected. And so what we know is that in a given individual, although SSRIs in general seem to be equally effective, some people, for whatever reason, respond to one medication and not the other. People might respond to Zoloft and not Paxil, or Paxil and not Luvox. We still don't have kind of enough evidence to show that we can kind of predict who that's going to be in. We do keep looking at different areas, and one thing that Dr. Simpson discussed is, the different types of OCD. Do people with more contamination symptoms, do they respond to one SSRI, whereas people with more hoarding symptoms respond to another? There's some suggestion, but there's no real clear evidence that we can kind of go by. And so given that we kind of know that all SSRIs are somewhat equivalent, how do we choose which one we're going to use? And one of the things we look at is adverse effects. And again, adverse effects is a tricky issue because one person's adverse effect is another person's bonus. And so somebody that is really agitated and has a lot of insomnia, a sedating antidepressant might be helpful. And so there are certain SSRIs that are more sedating. Other people, they get more kind of sedated and they need an SSRI that's more activating. And so each one of the medications we use with the SSRIs has a little bit differences in side effects. So we use that to kind of determine which we're going to go with. The other thing we look at is potential drug interactions. And so we look at what other medications somebody's on, and depending on that, we can look at the different SSRIs and which ones might have a negative interaction. The other thing we look at that seems somewhat obvious is past treatment response. Somebody comes in, they say, I used to be on Prozac for my OCD and it worked. It's probably a good place for me to start. The other thing is family history and of medication response. And like Dr. Simpson discussed, there seems to be some genetic component that clearly is involved in OCD. And knowing that we share some genes with our family, all things being equal, if I know somebody in the family, especially if that person has OCD, responds to Prozac or a particular SSRI, that might be the one I choose. Again, there's no perfect kind of way to do that, and it doesn't work all the time. But all things being equal, it might be something that influences the choice. The other thing is the presence of co-occurring medical conditions and psychiatric conditions, and looking how each particular medication might affect that differently. I'm just going to get a quick sip because my mouth is dry. So we use the SSRIs for a lot of different disorders. They're actually effective in all the anxiety disorders as well as depression. And yet there's a difference in how we use them in OCD as opposed to other anxiety disorders and depression. And one thing is dosage. In OCD, we often need higher doses of medication of the SSRI than we typically use for other anxiety disorders or depression. The other thing is how long it takes to respond. And so in major depression, often people will see some response even within the first 2 weeks, and greater response over time. In OCD, often it takes longer to start to see a response, sometimes 4 to 6 weeks, and sometimes as many as 8 to 12. And so it often takes 8 to 12 weeks to figure out if this medication is working for somebody or not. So this is the part where it gets really interesting, or for some of you, this is probably the point where you're going to close your eyes for a little bit. So how do SSRIs work? And I think I have a little laser here. And so how do SSRIs affect? So this is what we call a synapse. And a synapse is just a fancy name for where one neuron, which is called the presynaptic neuron, talks to another neuron. And it does this by sending out a transmitter. And these particular ones are serotonin transmitters. We also have what's called a serotonin transporter, or sometimes called a pump. And basically what this does is as serotonin pours out, and there gets to be a lot in the synapse, this transporter kind of sucks them up and puts it back into the neuron. What SSRIs do is they actually block this pump. So now all that serotonin is not getting sucked back up, so we have more in the synapse to go and hit the receptors. So in OCD, we've kind of looked at exactly where, once we kind of do that, where the medications are having their effect in OCD. And there are a couple of specific receptors that we have a lot of interest in. These are what are called autoreceptors. And what an autoreceptor does really is when there gets to be a lot of serotonin in the synapse, it'll hit the autoreceptor on the first neuron. And it's a way of saying, look, you're making too much, you're releasing too much, slow everything down. And so when it hits these 1D receptors, as well as 1B receptors, it slows down the release. And actually, when we give somebody a serotonin reuptake inhibitor, it increases serotonin, but actually not as much as you would think. And that increase actually happens fairly quickly, within a day or so. And yet we know that symptoms don't resolve in a day or so. So it's clearly not that initial release. But what we think happens is that as these serotonin hits these autoreceptors over and over again, actually these autoreceptors become less sensitive to it. And now over time, when serotonin hits them, it actually doesn't cause it to stop releasing. And so once we, what we call desensitize these, we actually get more and more serotonin release. And some of the receptors we think are involved in OCD is when it hits receptors such as 2C and the 2A receptor. So now we're going to kind of do what every good talk does, and we're going to talk about guinea pig brains. And so what have we learned from guinea pig brains? So the really interesting thing is that when we look at the brains of guinea pigs, we can actually look at specific kind of areas of their brain and see how much serotonin is being released and how long it takes to desensitize these receptors. And if we look at the guinea pig brain and we treat them, and in the past they've used Paxil to treat the guinea pig brain, and they've actually seen that in areas like the hippocampus and the hypothalamus, which we know are key components in causing depression, that it takes about 3 weeks for these receptors to downregulate, to desensitize, and to get that increase in serotonin release. Interestingly, if you look at an area called the orbital frontal cortex, which Dr. Simpson discussed, which seems to be a primary area in OCD, it actually takes 8 weeks of Paxil treatment to reduce the sensitivity of these receptors. And that kind of adds more validity to this model that it probably is the orbital frontal cortex that's involved. And again, that these kind of receptors downregulate at different rates. So if treatment for OCD is unsatisfactory, so if I treat someone for OCD, I'm giving them a particular medication, I get the dose up fairly to a high enough level, and they're not responding, what do I do? And so the first thing is to figure out, are they taking the drug? This actually seems like a silly question, but it's actually surprising how often people actually aren't taking the medication. Another thing that actually tends to happen more than you might think, especially with young patients who aren't used to taking kind of daily medications, is that people get into the habit of thinking, when I have a headache, I take Tylenol. Some people say when my OCD is bad, I take my SSRI. When it's not bad, I don't. And sometimes we actually don't think to explain to them that it needs to be taken every day. The other thing we go back to is diagnosis. Again, something Dr. Simpson talked about. If the medication's not working, I first have to also question my diagnosis. Is this OCD? Is it not something else? Could it be the worry instead of obsessions? Could these really be the worries of generalized anxiety? Could they be the ruminations found in major depression? Also, sometimes tic disorders. People can have very complicated tics that actually look like OCD compulsions. And so if the medication's not working, I have to go back and check and see if I actually have the right diagnosis of OCD. The other thing is co-occurring conditions. And we know that actually it's more the rule than the exception. That in OCD, people often will have another psychiatric illness. And that psychiatric illness can actually affect the ability to get better. And so often when another psychiatric illness isn't being treated, no matter how well you treat the OCD won't get better. This is actually often the common case when people have OCD and bipolar disorder. If the bipolarity and the mood instability isn't solved, often it drives the OCD. All right, so we're going to speed up. So effective strategies for managing treatment resistance in OCD. And so we have two big strategies: switching the medication to another, or augmenting and adding a medication, or adding CBT. There actually isn't a lot of evidence to guide us on what the better technique is, and it really is affected on a case-by-case basis. Some of our augmentation strategies include using atypical antipsychotics. And so if a person has a history of tics, we actually know they often have a better response than regular OCD patients due to these atypicals. And so that might actually lead me to augment instead of switching if they have tics. Also, people sometimes who have symmetry-related obsessions do better on atypical augmentation. People have a partial response. So if I'm giving someone a medication and they're responding but not fully, I might decide to try to augment that response as opposed to trying another medication which might not work at all. The other thing is a need for more rapid response, and we're going to discuss how that adding certain medications, actually we can get somewhat of a rapid response. And so if somebody's not responding and I need to get a quicker response, switching the medication can often take a long time for it to build up in the system, and again, waiting that period for it to start working. So our evidence for switching another SSRI is about 11 to 33% who switched from one to the other that wasn't working got improvement. One of the questions is always, do we switch somebody from an SSRI to clomipramine? And I can say that in general practice, often people will decide to, if they give one or two trials on an SSRI, give a trial of clomipramine. And again, they have the thought that there might be something a little different about it. So now we're going to very quickly go over augmentation strategies. And so the most evidence-based augmentation strategy that we have is adding low doses of antipsychotics. It's always important to kind of talk to patients about this because often when people hear the word antipsychotic, they get nervous. These drugs are also called neuroleptics, and these drugs actually affect both dopamine and serotonin. We use them at lower doses, and so these aren't the same doses that we use for disorders such as schizophrenia. The older drugs called the typicals like Haldol, and some of the atypicals that have been shown to be effective are Risperdal, Abilify, Seroquel, and Zyprexa. And so what do we know about low-dose antipsychotics? Out of all the augmentation strategies we have, it appears to have the most evidence behind it. We know that about a third of people will get a response when we augment with antipsychotics. Also, we know that people will often usually get a response if they are going to respond within a month. And they seem to be, while they can help all people with OCD, that it seems like they work even better on people that also have a tic-related disorder along with the OCD. The big problem with these atypical antipsychotics is what's called metabolic syndrome. And so some people will get metabolic syndrome, which consists of weight gain, sometimes an increase in cholesterol, or low-density lipids as well as triglycerides. And also people can sometimes get some insulin resistance, almost a pre-diabetic condition. And so this is the downside of atypicals. Some atypicals, such as Zyprexa, cause this more often. Some, like Abilify, seem to cause it less often. So now we're kind of going to get to the big stuff. What is the current stuff going on? So what's hot? Oh, no. Okay, no. So really the hot thing in psychiatry right now, which is not immune to fads, is glutamate. And glutamate has actually been shown to work in a lot of disorders. And so there have been a lot of studies early on, especially on schizophrenia, but now actually also on depression, on using drugs that modulate the neurotransmitter glutamate. And what do we know about glutamate? It's the main excitatory neurotransmitter in our brain. And in OCD, we've actually had some interesting findings. One finding that we've seen is that the cerebral spinal fluid of people with OCD compared to people without seems to have higher levels of glutamate. And so there's a question, do people with OCD have too much glutamate? We also look at some gene studies, and some of the genes that have been associated with OCD include genes for some of the glutamate transporters, particularly one in a similar way, the way that serotonin has a pump. There seems to be a gene involved with OCD that affects the neuron pumping back glutamate back up into the cell. And we also kind of have seen several treatment studies work. And so it does appear that glutamate is an important neurotransmitter in OCD. And this is our kind of mini model of the circuit that we talked about. And this is this cortical striatal thalamic circuit. And as you see here, there's glutamate. And so it would make sense that glutamine would be a key player in OCD because it is responsible for a lot of the transmission in this circuit. And so the first drug we're going to talk about that affects the glutamate system is a drug called riluzole. We were lucky enough to get a lot of these slides from Dr. Christopher Pittenger, who's one of the real experts in glutamate. And all the medications that affect glutamate affect it a little bit differently. And so the way riluzole seems to work is that we have cells that's similar to the way serotonin, they have pumps that pump glutamate back into the cell. And these are called glial cells. And so what we know is that riluzole blocks this pump. It actually increases the activity of this pump. And so we get more pump of the glutamate out of the cell, decreasing our levels of glutamate. Riluzole also seems to work by affecting sodium channels that have the electricity run down. And so it decreases the amount of the electricity going down the neuron, causing to the release of these neurotransmitters. And here's an open label study of glutamate. And again, these aren't placebo-controlled trials, but it appears that glutamate actually works fairly well, seeing about 50% of people having a response to adding the addition of riluzole. Another drug people use is called memantine or Namenda, which is commonly used for Alzheimer's disease. And this affects the glutamate system a little differently. This actually blocks one of the main glutamate transporters, the NMDA receptor. And by blocking this, again, we get decreased kind of transmission of glutamate. And there have been several studies, again, smaller studies in open trials, of using the Namenda as an augmenting strategy in OCD. There are many other drugs that we're also using that affect the glutamate system that we're trying for OCD. Probably one of the most interesting is a drug called D-cycloserine. And so the way D-cycloserine works is actually part of this NMDA receptor. In order to get neurotransmission, not only does glutamate have to hit it, but also glycine or D-serine, which actually hit another spot. And so for that communication to happen, you need both glutamate and one of these molecules. And so what we know is D-cycloserine works at this kind of what we call a co-agonist site. And so the interesting thing about D-cycloserine is it's actually used in a different way than we use most drugs. It's actually used in combination with CBT. And what we know is that these NMDA receptors are involved in learning. And what we do is we've tried to give people some D-cycloserine, not on a daily basis, but just before getting exposure and response treatment and seeing if they actually get a better response. There have been several studies, and the studies kind of have gone back and forth. One thing that seems clear is that we often get a faster response. And so even if a group of patients responds to exposure response prevention, the group who's getting the D-cycloserine actually responds quicker. And so that's not an unimportant thing in OCD. Again, these trials have been difficult because it really is about figuring out how early to give the D-cycloserine. And some that have given it 4 hours before haven't done as well as when we give it 2 or 1 hour before. And so again, this is something still figuring out. But again, it's a really exciting thing in psychiatry. We also know that other medications like ketamine, which similar to Namenda, blocks the glutamate receptor. It actually blocks it much more strongly. And if you open up any kind of psychiatric journal these days, the hot thing is looking at ketamine actually as a treatment for depression as well. And it actually, people seem to have a very rapid response to ketamine. Other chemicals we use are things like N-acetylcysteine, lamictal, topiramate, glycine. These have all had kind of somewhat mixed results, and again, probably the best results we've seen so far out of these glutamate modulators appears to be with the riluzole and the Namenda. And so lastly, I'm going to talk about a drug that works differently called ondansetron or Zofran. And Zofran, its main use is usually for kind of nausea and vomiting after treatments like chemotherapy and surgery. And what it actually does, it affects a specific kind of serotonin receptor, the serotonin type 3 receptor. And it blocks that receptor. And what we think is that by blocking that receptor, it affects dopamine. And the dopamine system is another system that we think might play a role in OCD, and that it might be an increase in dopamine and too much dopamine neurotransmission that affects OCD symptoms. And a very interesting finding looking at people with cocaine addiction, and they've tried to treat cocaine addiction with ondansetron. And the interesting thing is that ondansetron, when looking at the brain, was shown to actually inhibit the right orbital frontal cortex. And so what would make sense that it would be a useful drug in OCD, where we know that the orbital frontal cortex can be hyperactive. And here's a recent study. This is actually a placebo-controlled trial, relatively short, and as you can see, that this is people taking just fluoxetine, and these are the people taking the fluoxetine and the ondansetron. Ondansetron is usually well tolerated. Currently, it's undergoing a larger placebo-controlled trial. The last thing actually I did want to discuss is amphetamine and a stimulant. And stimulants have always been a very controversial area in OCD, many people thinking that they make OCD worse. It appears in some cases they do, but in other cases, actually we've seen some effect from adding a stimulant to somebody's SSRI or alone for OCD. And so there have been some smaller studies. Very interestingly, they were doing a study of using a stimulant, and they wanted to have a placebo group. But they figured that everybody in the placebo group would know they weren't taking the stimulant because stimulants cause side effects, some hyperactivity, some agitation. And they said, well, it's not really a good study if everybody knows that they're not taking the drug. So instead of having a placebo group, they actually had one group take the stimulant and another group they gave pills with caffeine in it, thinking that, again, they would have the stimulating effects and not know that they were actually not on the stimulant. And it turned out that actually both groups did well for OCD. And one of the interesting things is that maybe kind of the same way that the stimulant works, that the caffeine actually was also helpful in OCD. Again, there hasn't been a ton of research, but it is a kind of growing area. I know that was a very quick bounce back and forth. Like they said, we're going to kind of, I think, have some time to talk later in the day during the lunch session where people can ask more questions. Thank you very much.